to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. And I'm your moderator and narrator, Uriel Riley. Peace, YouTube. I took a nice little break, gave you a day or so to go through the information and catch up on the replays. So I am honored to be here with you on this beautiful Tuesday as we pick up in chapter 17. Wow, I didn't even know we made it that far. Wow. Page 284. Peace, YouTube. Welcome to the peaceful part of YouTube where we read books and learn from masters. We are in the thick of it. This is episode 49. All right. This book reading. Down at the bottom of page 284. Subglottic edema. See figure 17.1. Subglottic edema is the most serious type of post-extubation edema. It is the one most commonly necessitating reintubation or tracheostomy. Subglottic edema is more common in infants and children because of the small internal diameter of the larynx. In the newborn, a 1 millimeter edema is in the subglottic area will reduce the cross-sectional area by 35%. The subglottic region is subject to trauma because of the fragile epithelium, loose submucosal connective tissue, and the complete cartilaginous cricoid ring, which prevents any external expansion. In the small child and infant, the cricoid ring has the smallest diameter in the larynx and trachea and is subject to maximal trauma during intubation. If a post-extubation edema does not respond to routine measures, subglottic edema must be assumed. This is a potentially life-threatening problem. The response of subglottic edema to intravenous steroid therapy is controversial. However, most would agree it should be administered. The definitive therapy is reestablishment of an artificial airway. Yes, that's right. All right, we're at the top of page 285. There we go. I wanted to make sure that the sound is good for you. It's not overpowering. Thank you so much for the likes and subs. We're pushing towards 600 on this peaceful part of YouTube where we read books and learn from masters. So, at the top of page 285, ulceration of tracheal mucosa. Next to hoarseness, sore throat, and edema of the glottis, the most common complication following endotracheal extubation is ulceration of the tracheal mucosa. This usually occurs at the site of the cuff or on the anterior wall where the tip of the tube has abraded the epithelium. Pain with coughing is common. Tracheitis is not uncommon, and hemoptysis hemoptysis is rare. Conservative therapy consisting of aerosol and reassurance is adequate. Sequelae are rare. Vocal cord ulceration, granuloma, and polyp. Vocal cord ulceration, granuloma, or polyp is suspected when hoarseness persists for more than a week. The lesions are usually unilateral and are believed to be caused by 1. Intubation trauma, 2. Tubes that fit tight in the glottis, 3. Protracted cough, 4. Excessive movement of the tube, head, or neck during intubation, 5. Allergic reactions to the tube or lubricant. The diagnosis is readily made by indirect visualization of the glottis. The incidence is virtually unknown. The therapy is surgical excision. Peace, YouTube. Thank you so much for being with us. Highest heart love. Thank you so much, Tasha. Oh, Tashia Bowman. Highest heart love. We're reading medical books, and this is the peaceful part of YouTube where we read books, learn from masters. I'm Master Fitness Trainer Uriel Riley, and we are reading Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Yearbook Medical Publishers, 1979, second edition. So, gratitude. Thank you for joining us. Peace. All right. Vocal cord paralysis in the bottom of page 285. Vocal cord paralysis is another lesion of unknown frequency. Unilateral cord paralysis occurs with surgical intervention in the neck and upper chest secondary to recurrent laryngeal nerve damage. Bilateral cord paralysis has been reported following endotracheal intubation, and many causative factors have been suggested, including the possibility of ethylene oxide sterilization. At the present time, the relationship between endotracheal intubation and vocal cord paralysis is unknown. Respiratory care practitioners must accept the fact that some relationships may exist. However, the incidence and causative factors are not clear. Laryngotracheal web. The necrotic tissue at the glottic or subglottic level can lead to fibrin formation, which combines with cellular debris and secretions to form a membrane or web. These membranes may occupy as much as 2/3 of the opening between the vocal cords or subglottic lumen before obstructive phenomena can become clinically manifest. The onset of ventilatory difficulty is usually sudden because of a portion of the membrane freeing itself and totally obstructing the airway. The treatment is simple and successful when recognized early. Aspirate the web with a suction catheter. See a solution. There we go. We want to make sure we take note of that. All those in the playlist and reading along. Thank you so much. We're at the top of page 286. Wow, we've came so far. This is amazing. Thank you so much. There are some rare circumstances in which surgical removal may be necessary, but in almost all cases, aspiration of the web will cure the condition. Laryngeal webs are most often seen 4 to 5 days after tracheal extubation, but they have been reported to occur as late as 2 months to 2 years post extubation. When sudden airway obstruction occurs several days following extubation, this phenomenon should be suspected. The membrane is often seen by direct visualization during the process of reintubation. Aspiration is essential because the web may obstruct an endotracheal tube or be pushed into a main stem bronchus. Peace, YouTube. Thank you for reading with us. Highest heart love. We are in the middle of page 286 for those reading along in the 17th chapter. So, highest heart love and honor. Post extubation tracheal stenosis. Tracheal stenosis is a lesion that occurs from 1 week to 2 years following endotracheal intubation or tracheostomy. It is a scarring of the trachea caused by the healing process that results in structure of the airway. Oh, stricture of the airway. I want to be clear. A concomitant problem is tracheal malacia, the destruction of the tracheal cartilage, resulting in collapsing of the trachea during inspiration. Malacia and stenosis often occur together. Stenosis often occurs alone. Malacia seldom occurs alone except in infants. 20 years ago, post extubation tracheal stenosis was rarely a problem, since few patients survived ventilator care. This fact provides the proper perspective through which this problem must be viewed. Tracheal stenosis is a real and serious complication of tracheal intubation. Everything possible must be done to decrease its incidence and severity. However, tracheal stenosis is never a contraindication for intubating or using cuffs on artificial airways when indicated for proper air care. Much of the literature concerning post extubation tracheal stenosis is confusing, controversial, and misleading. Although the authors have attempted to present the most universally accepted viewpoints on this subject, the controversy is so vast and the facts so scanty that personal opinions based on clinical experience are difficult to avoid. We encourage the reader to make liberal use of the reference material. However, we feel confident that the following presentation is a clinically useful and dependable guideline for the respiratory care practitioner. Top of page 287. Incidence. The incidence of tracheal stenosis following tracheostomy with uncuffed tubes has been reported to be less than 2% with cuffed tubes. The incidence has been reported in the range of 5%. The real value of these statistics is to establish that tracheal stenosis is a significant complication of endotracheal or tracheostomy procedures with or without cuffs. The significant lesions resulting from ventilator support through cuffed tubes are usually found a few centimeters below the stoma at the cuff site. In patients receiving mechanical support of ventilation with cuffed tracheal tubes, studies report an incidence of tracheal stenosis in the range of 1 to 20%. This variability is due to the different methods used to make the diagnosis. In studies where the criteria were symptomatic, presentation of dyspnea, loss of exercise tolerance, stridor, and recurrent pulmonary infection, the incidence was significantly lower than in Prospective studies utilizing techniques such as laminograms, bronchograms, and bronchoscopy. A tracheal obstruction of less than 50% seldom results in clinical symptoms. In our experience, the incidence of symptomatic tracheal stenosis requiring surgical repair is approximately 0.5% to 2% in patients receiving ventilator support with cuff tubes. Causal factors. The incidence of significant tracheal stenosis at the site of the tracheostomy stoma seems to be less related to respiratory care factors than cuff site stenosis. Although the authors do not wish to understate the importance of stenosis at the stomal site, it is recognized that a great responsibility for decreasing that incidence belongs to the surgeon. Respiratory care factors which may contribute to stoma complications are too large a tube, excessive movement, and trauma from the tube. It has been shown that regardless of the type of incision made in the trachea, the ultimate loss of cartilage at the stoma is directly proportional to the diameter of the tracheostomy tube employed. Wow. Oh my goodness, this is so good. Thank you so much. Hi, it's Heart Love. Yes, this is the peaceful, quiet part of YouTube, the smart, gifted, talented part of YouTube where we read books and learn from masters. So, yeah, this is not Dummyville. This is brilliance in motion, greatness in motion. So, you're not going to see anything but the top notch here. You know, we got top notch information, top notch people, minds, and beautiful, high level learners and beings on this channel. So thank you so much for being here. Much honor and respect. The respiratory care practitioner must be primarily concerned with those factors involved in the prevention of tracheal stenosis at the site of the cough. It appears there are 6 factors that play a significant role in the incidence of post-extubation tracheal stenosis at the site of the cough. 1. Cough pressure. 2. Time. 3. Perfusion. 4. Infection. 5. Movement. And 6. Toxicity. Yes, let's get to it. This is so great, right? Super high level. I'll put the vocabulary. It will be the um, in the description when I upload the video. Thank you so much. See, when it's live, there's no commercials, right? and those reading along, we just can read in the book and take notes. So, top of page 288. Here we go. 1. Cuff pressure is the factor that has received the most attention in recent years. The realization that cuff pressures are significant in tracheal stenosis has led to a variety of cuffs designed to decrease the pressure exerted on the tracheal mucosa. 2. Time has been assumed to be a factor. It seems intuitively correct that the longer a foreign body exists within the trachea, the higher would be the incidence of complications. There is evidence to support the assumption that the incidence of tracheal stenosis increases with time over the first several days. However, in our opinion, there is a questionable relationship between the severity of tracheal damage and the duration of tracheal instability or intubation. That was two. Yeah. All right. 3. Perfusion or circulatory instability is common in critically ill patients needing mechanical support of ventilation. Up to 60% of patients receiving artificial airways and mechanical support of ventilation have significant episodes of hypoperfusion while cuffs are inflated. It is believed that hypoperfusion states are extremely significant in causing damage to the tracheal mucosa at the site of cuff inflation. Peace, peace. Welcome, YouTube. Thank you, all the new viewers and book readers. We're a part of the book lovers community. Highest heart love. Yes, super high level information, super high level vocabulary makes for super high level mind and body. So thank you so much for being here and reading with us. 4. Infection has been postulated as a significant etiologic factor in tracheal stenosis. Contamination of the trachea by bacterial colonization is unavoidable. Actual tracheal infection is uncommon with proper care. Tracheal contamination does not play a significant role in the etiology of tracheal stenosis, whereas infection is a well documented contributor to the incidence of tracheal stenosis. 5. Movement. Movement, weight, or tension on the tracheostomy or endotracheal tube may lead to higher incidences of stenosis. This is undoubtedly due to 1. Increased tissue pressure on the stoma. 2. Increased movement of the cuff. 3. Irritation to the tracheal mucosa, the movement of the cuff. And yes, the role that movements of the vocal cords and trachea play in increasing post-extubation sequelae, both in the spontaneously breathing and ventilator patient is not exactly known, but it has been documented that patients who are well sedated and do not resist the ventilator are less likely to suffer such damage. The use of lightweight swivel type connectors and tubing for the respiratory care equipment is mandatory. Patient movement must be accomplished smoothly to avoid excessive tugging on the tracheostomy or endotracheal tube. 6. Toxicity. Toxicity from chemical irritation of tube material has been named as an aggravating factor, particularly following ethylene oxide sterilization. If this oxidizing agent is not completely aerated from polyvinyl plastics, tissue toxicity may result. Prospective studies using ethylene oxide sterilization techniques with proper aeration have revealed an absence of toxicity to tracheal tissues. Allergic reactions are rare, but must be considered a type of toxic reaction. And we'll pause right here. Continue back with chapter 17. Laryngeal and tracheal complications of clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Highest heart love, Owen Holmes. Thank you so much. Right? We're giving it to the people for free. Thousands of dollars of information. People to help can take notes on this and you know help them in their MCAT or becoming a RES tech, MTechs, OR techs. We love all the nurses and healthcare providers. We are a part of that community. So we want to give people the best, right? And when we are healing ourselves and mastering ourselves, we're spiraling that energy out to the world, right? And that enables us to be able to help others and to help heal others. That's why it's important for us to heal ourselves. So it's information for you, for the people, for the light workers out there, shaking it up. Love you so much. Thank you so much for the likes and subs. We're getting towards 600 in this channel where it's peaceful and we just read books and give each other gems. We lift one another up, love on one another, stay positive, right? Highest heart, love, and honor. Thank you so much. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Peace. Thank you so much. I love y'all. Yeah, when we reconvene with chapter 17, we'll see you soon, right? We have the grocery giveaway tomorrow. We have beautiful, beautiful meditation with the great Lorianne Speed from Canada. So, yeah, it's all coming together. The light workers were all joining, holding ones up, and uplifting the people, and giving the light to the world. Information, right? Self mastery, what matters. So, thank you so much for being here. Let's have a glass of love water. Cheers to you. Cheers to our family and friends, right? We want the best of them. We're going to sing I Love You after this. And we are going to the White Cloud tonight to rest and do some healing work. Thank you. Cheers to you. Mm. I love you. I love you. I love you. I love you. Thank you so much. Peace, peace. Yeah, thank you so much. Oh, highest heart, love, and honor. Yeah, yep. This is the intelligent part and peaceful part of you too. So honored to be able to bring this to you. Information that we do on this channel is for the people. I love you to my daughter, my parents, family, and friends. We made it through another month, right? We're going into October. Stay strong. Remember, go out and take your walk. Look up. See what you see. What resonates with you, right? Say hi to the birds, to the bees, to the butterflies, right? And they'll say hi back to you, all right? I love you. I love you. I love you. Because I love you. Have a wonderful evening. I'll see you in the white cloud. We're doing healing and motivational speeches, writing poetry. I'll see you there. Peace, peace.